This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Next, we're going to have Kimber Stanhope moderate our panel discussion. So could each of our three panelists come up? And they're going to give us their comments. And then all of the speakers are going to come sit in these chairs, and we're going to hear from you guys. Kimber is our treasured colleague from UC Davis, and she spoke at our Sugar Co-Symposium, and you'll hear her again because her results get more exciting every year. She's one of the best methodologists for examining in a controlled way the effect of different nutrients and types of sweeteners and sugar on, I'll say, deep metabolism, really sophisticated measures of what it's doing to our cardiovascular health. Thank you, Kimber.
Well, I would first like to start off with an introduction of our three panelists. We have Dr. Larissa Duncan. Dr. Duncan is an assistant professor in the Family Community Medicine at UCSF School of Medicine. Her focus of her research is mindful parenting and its effect on psychological well-being, quality family relationships, and coping with stress. Now, when I read that, I go, like, what a great thing to be expert at. Not just at the scientific level. Does she have perfect kids? And everywhere she goes, I mean, wherever I go, people are watching me to see if I eat sugar. Everywhere she goes, are they watching her to see if she's going to snap at her kids? Our next panelist is Dr. Erika Gunderson. And Dr. Gunderson is an epidemiologist and senior research scientist at the Division of Research, Kaiser Permanente, Northern California. And the focus of her research, well, she has everything with regards to gestational diabetes. But one of the things I noticed that was especially interesting to me is that she's actually looking at the effects of lactation, not specifically only on the child, but on the future well-being of the mother and the development of obesity and metabolic disease. Now, this is really interesting to me because I remember in 1978, Nutrition 111, as an undergraduate, we were actually discussing lactation and its physiological energy requirements. And I raised my hand and said, is it possible that when women stopped lactating because of the introduction of formulas, that actually promoted future weight gain, and that might have a relationship to the obesity epidemic? I don't think we called it an epidemic back then, but that's what I was thinking about. And the answer wasn't memorable, as evidenced by the fact I don't remember it. But I'm really happy to know that this answer is going to be forthcoming. And then finally, our third panelist is Dr. Asia Ferrara. She's also with the Division of Research at Kaiser Permanente, and her list of focuses with regard to research are very widespread. Those related to diabetes and gestational diabetes, she's looking at the effects of BPA exposure. She is actually has a research study on the comparative effectiveness of diabetes prevention strategies. And she's also one more researcher looking at the effects of gestational weight gain on gestational diabetes. Welcome to our panelists.
So I very much enjoyed all of the other speakers' presentations today. I learned a great deal that I think is so relevant to work that I'm involved with and collaborating with others here at UCSF and around the country. And most of my work with my 2-year-old, as was referenced in the lovely introduction, and with the pregnant women and families I work with, is around using mindfulness to help support healthy development. So I'm a developmental psychologist, and I really think about those gene-environment interactions from that very earliest moment. I loved the reference to those teachable moments. I think about developmental transitions as being very teachable moments for people. They might be slightly afraid of what's coming next and might be more open to learning new strategies for managing their health behavior. And then I also want to just mention the social ecological framework. This is a well-established model that really thinks about the person nested within many layers of context that influence their functioning, their health, and their development over time, which we see as also a part of this model. And I think we need to think about how we can empower that individual in the middle of those circles to make healthy choices in terms of what they're eating, how they're interacting with their family members as we think about those ACE qualities of family development, but also think about what's happening at those broader mesosystem, exosystem, macrosystem levels. I'm just thinking about food insecurity and food deserts. I heard a really interesting presentation last week at an integrative medicine conference about urban farming initiatives with teens in Baltimore, and I'm thinking some of those teens are going to be the pregnant women in the future. We heard that referenced in terms of intervening early. And so I just want to plant those seeds of those sorts of broader systemic levels of intervention we should take into account. So a lot of the work we're doing with mindfulness is in teaching pregnant women mindfulness skills as part of their childbirth education with Nancy Bardakey's mindfulness-based childbirth and parenting education program. You can read more about that. There's a flyer outside on the table. We offer that here to the public at UCSF. But one of the issues with that program is that it's not widely available to lower income women who have less resources to attend programs like this. And this was referenced. How do we, if we're beginning through these mixture of studies to learn more about what may be effective, how do we get those effective interventions into people's hands? How do we bring something like mindfulness training to a woman that doesn't have hours every week to attend a mindfulness program that might help her cope with stress, that might empower her to make healthier coping choices in dealing with some of the other systemic pressures that are facing her during her pregnancy? And then it was mentioned my work on mindful parenting. I really want to honor John and Mila Kabat-Zinn, who've done just tremendous work in writing about mindful parenting, about thinking about how those moments in the life course can perhaps not turn into those ACE factors that are endorsed on questionnaires later in life. And so we're thinking about how can we bring this mindfulness in pregnancy, mindfulness in other stages of development, family interaction into people's lives in a really accessible way, both in terms of introducing something that's easy to do, like taking a few moments to really attend to the breath in a stressful situation. But how do we teach them? And we see women really listen to physicians, they listen to other women friends, and there's an existing model of group-based prenatal health care called Centering Pregnancy that's already pretty widely disseminated. And what this model does is allow women with the same month due date to effectively pool their minutes for their ACOG recommended prenatal health care visits and to meet together as a group with a qualified healthcare provider who then gets 2 hours to talk with them about all of their concerns and offer a health education curriculum. And we're working with the developers of that program to introduce mindfulness training into that model. So here in San Francisco, we're working with the Homeless Prenatal Program and the midwives at San Francisco General Hospital to allow low-income, predominantly racial ethnic minority women to get this training as part of prenatal health care they're receiving under Medi-Cal. So very accessible form of this training. And we're just beginning to look at our data from this study, but we know from standard centering pregnancy, before we even introduce this additional mindfulness-based stress reduction and mindful eating, bringing that additional awareness to nutrition, that there's some impact on healthy weight gain in pregnancy. Jeanette Ikovics, who's done the large randomized controlled trials of centering, presented data here at UCSF in December suggesting an impact already with the standard centering pregnancy program. So I'll just plant that seed with you as one intervention modality that may perhaps be beneficial, and just give you a close-up of this beautiful picture of a group of women who've been through the centering pregnancy program, and in a picture here with their babies. One thing that's noticeable about this picture is that these women and their babies are in a circle, and sitting in a circle is one of the essential elements of the centering pregnancy model. Something you wouldn't normally spend a lot of time thinking about when you're developing your intervention, but it's so indicative of the empowerment focus of this model that it's not a hierarchical provider-patient relationship. The provider is part of that circle, and all of the women's voices and their collective knowledge and their cultural background is brought to bear on the discussions in the group. And recent data suggests that providers who are able to lead the group with a style of leadership called facilitative leadership, so it's less didactic, it's really empowering these women to chart their own weight, so that weight monitoring, set goals for themselves around healthy nutrition and pregnancy, bring in snacks to share with each other that may be some food from their cultural context or country of origin, but in a way that they're thinking about the health of their babies in the future. And so what we're adding to that is things like loving kindness meditation, mindfulness of the breath. I mentioned mindful eating. So really thinking about these other strategies that can help with some of the psychosocial elements with the depression and anxiety that may be more prevalent for them, to empower them as best we can as they work within their cultural milieu to raise the healthiest babies they can. So I give you my future direction slide. These are our future directions. We're all working on this initiative in one way or another, and I was so impressed by all of the other speakers and the importance they place on these issues. So if we think about these babies and the babies they'll have and how we might impact longer-term health and developmental framework. And I thank you for your attention.
Hi, I'm Erica Gunderson. Thanks so much to the organizers for inviting me to participate. It's really a fascinating conference, and I've really enjoyed every single speaker. I just wanted to say that the last time I participated, I guess I spoke on sleep deprivation during the postpartum period in pregnancy and how that influenced obesity in women. So as you know, this issue of stress, I think, carries that theme forward, and the focus here on stress is so important, as pregnancy really is a stressful time in so many ways, not only emotionally and behaviorally, but physiologically. And so I think the talks today really focused on the pre-pregnancy period as being a key component of health in women and long-term health that we really haven't focused on very much. And there's not a lot of research on it for pragmatic reasons of the difficulty of recruiting women pre-pregnancy. So what I want to talk about is some of the research I have ongoing, but also this opportunity that I think of rephrasing sort of the paradigm of focusing on interconceptual health of women. So the pre-pregnancy phase sort of leaning over into this between pregnancies, because once a woman delivers, that postpartum period for that pregnancy really is a preconceptual or interconceptual time point, and it's a critical period for our intervention, and it really presents an opportunity. And what my research really focuses on right now is can postnatal feeding compensate for the adverse fetal environment? And conversely, can it compensate for the adverse effects of pregnancy and the adaptations to pregnancy on the women's health? So I want to talk a little bit about lactation and factor that into the equation of a lot of the presentations you heard about glucose intolerance of pregnancy and pre-pregnancy obesity. Once women deliver, it's this postpartum return to preconception weight, but also what's happening in the early life feeding period, as well as that postpartum adjustment, and how does lactation influence maternal obesity, and how does maternal obesity influence the capability to breastfeed? And I know this audience is very familiar with all the health effects of breastfeeding for the child. They're numerous, and as well as there are effects for the woman, but that's much less studied, and that's the focus of my research, is to look at lactation and prevention of type 2 diabetes in women. But I want to start out with this infant feeding and health for the child. We know that babies are grabbing onto all kinds of things and putting them into their mouth. So, there's this part of what are they being exposed to, but early life feeding has been known to play such a critical role, but it hasn't been explored very much in context of the intrauterine exposure. So combining those two facets of early life, I think, are where we're headed with research. And you may have seen this particular model, which is not recent. It's from Martorelli in 2001, and it's a model of how what the speakers addressed is intrauterine undernutrition, increasing risk of obesity and fatness in childhood and adulthood, and as well as overfeeding, increasing the risk. And what you can look at is sort of what causes poor nutrition or poorer transfer of nutrients for the fetus, and it's maternal stress, the smoking, the dietary quality, and illness, which could restrict the growth of the fetus. And what are some of the components that increase overfeeding of the fetus and actually promote adult and childhood fatness? So you see this U-shaped distribution with both underfeeding and overfeeding be associated with higher risk of child overweight. And some of those components we touched on, all three of them, and there are, of course, more as we move into metabolic lipids for pregnant women. But what you can see at the bottom there is breastfeeding lowering the risk. And the research question is, can the breastfeeding compensate for some of these adverse effects that the fetus is exposed to? And that's a postnatal intervention for the fetus and the child, actually. And some of these studies have looked at this question, but there are very few that look at these infants that were exposed to this overnutrition and looking to see if breastfeeding has an impact. There are animal studies, however, that are quite clearly showing that modifying the early life nutrition does reduce fatness in the animals. But in human studies, we have one study that has some design issues that found a null association among the offspring of type 1 diabetic women. But more recently, Tessa Kroom looked at the offspring of diabetic mothers and saw an association for 6 breast milk months. And that's sort of a composite of breastfeeding over various durations that's a weighted average of exclusive and mixed feeding. And she found a lower BMI and lower adiposity at age 6 to 13 years in the offsprings that had been exposed or unexposed to maternal diabetes in utero. So the exposed offspring to maternal diabetes looked very similar to the unexposed in terms of fatness. So it found a very strong protective association with breastfeeding. And I mean, I have to put that in, before I go to this slide, I have to put this in context that our breastfeeding rates in the US, while they're improving, always improving, there are still only 48% of infants are being breastfed at all by 6 months. So we have a long way to go, and exclusive breastfeeding is quite low at that point in time. It's in the 20s. So we have a long way to go to meet any of the recommendations on breastfeeding, and there's a real effort nationwide, as you well know, for the Surgeon General to promote more breastfeeding and especially among women of color. But here I want to touch on the health of the women, and this is a very nice model about how early life of women can affect their risk status for developing cardiovascular complications during pregnancy, as well as their long-term cardiovascular risk in middle age. And that's the red line, where you have a woman that's exposed to adverse effects intrauterine with that elevated red line. And then you may or may not see her higher risk during early life, but once she becomes pregnant, she develops complication and later goes on to develop heart disease or stroke. And the dotted line reflects sort of the healthier woman that adapts to pregnancy well and didn't come into pregnancy with these adverse childhood or early life compromise. But this line that I'm adding here in orange is what's missing for me from these models is what does lactation do to potentially reset and help the woman recover to her pre-pregnancy state? So the orange line is actually below the dotted line, not where the dotted line is sort of moving towards higher and higher accumulation of weight and obesity, and the lactation might help ameliorate some of that effect. And this is a slide that I borrowed from a published literature from Essa Davis, and it's a very interesting model that kind of incorporates the social, cultural, physical, environmental stress in that green box. All of these things we've been talking about, genetics and race, ethnicity, and stressful life experiences. And then she talks about stress assessment during pregnancy and health behaviors, and goes on to show how that can promote excessive gestational weight gain and persistent insulin resistance during and after pregnancy, and then postpartum weight retention. But what I find interesting about this model, again, lactation is not mentioned as a possible behavior that can help reduce the risk of women developing type 2 diabetes. And that's some of the research that I'm currently doing. In my SWIFT cohort of women with GDM is we're measuring lactation intensity and duration prospectively in the cohort and screening them annually for type 2 diabetes after pregnancy and finding very strong protective associations. So I really appreciate your attention, and thanks so much.
Good afternoon. I'm Asia Ferrara, and I was invited Sunday night to substitute Dr. Larry Rand, and I don't know if I misunderstood the instruction or what I was supposed to do, but I do not have slides. So my understanding was more about what I have learned from this symposium, and I took a couple of notes during the talks, and now I would like to share them with you. So starting with Dr. Catalano, so what we have learned, there is this debate, is obesity or hyperglycemia leading to adverse effect of maternal and infant outcome? And definitely both, but we are still treating hyperglycemia, and we know the effect of treatment on hyperglycemia. What we do not know is if a treatment of obesity reverse the effect we observe during observational studies. So definitely study on treatment of obesity and pregnancy outcome are needed, but it's also a difficult study to do because when we do this intervention, it's during pregnancy, then we have all the gestational weight gain intervention. Many of us have talked about, many of us are doing them, but gestational weight gain intervention do not treat obesity, may reduce the increase of obesity already existing. We do then treat obesity before women who wants to get pregnant. We don't know if it's safe to lose weight before getting pregnant. And we may induce stress if we have women losing weight just before conception, and maybe even avoid conception if they lose weight. So there is more a question about, is really need, the intervention is really needed at the population level among reproductive women, or women of reproductive age. And I don't know, Dr. Ederson, I just have a commentary published on JAMA yesterday calling for an intervention on these women of reproductive age, especially for increasing physical activity that happen before pregnancy, then look at that. It's very difficult because then we have to wait for women to become pregnant. And it's a study that requires an incredible amount of energy, resources. The sample size must be huge. The ability to follow women not only to get pregnant, but after pregnancy. So it's very hard question to answer, and so the debate about hyperglycemia or obesity on effect of BMI, I think, can go for many other years until such study can be done. For Dr. Lasting, that we have learned, I think, that the importance of estrogen during pregnancy, and most of all, the importance of the need to study the endocrine disruptors, toxics that are in the environment. And this requires an intervention, ecologic intervention, of course, to reduce this type of the endocrine disruptors. But still we can have some individual tailored intervention in order to educate women to reduce the use of plastic or other compounds. Very interesting things emerge from this symposium is stress. And Dr. Lasting showed us that the effect of stress can already be identified in the early conception and embryo, in the early cells of conception, and is already an effect on telomere length and mitochondrial function. And so that's what would lead us to think about maybe more feasible even to help women to reduce stress before or to cope with stress. So they have some stress reduction when they're thinking to get pregnant. Dr. Abram showed us that there is a life course of stress on effect on pregnancy and in its outcome. So it probably is important at the same time not to assess if there was a stressful event during childhood, and the intervention there could be how to help women to cope and with their stressful experience. Dr. Laraya also one important point that we are already, all of us knew we need to improve diet, increase exercise, reduce stress. But we know that many studies were unsuccessful. So we really need to refine the type of intervention for each of these three components. Not only the calorie, but the quality of a diet, probably for physical activity, be more realistic and more tailored to the women, possibility to exercise, and for sure for stress. So stress, we have more to identify more what is the background. There was a stressful event before, just because we assess stress by a questionnaire, and now we need to help women to cope with the core event of their stress. Finally, with Dr. Phelan, although I have read their paper many times, only today when she was presenting, I realized one thing. So in her intervention study, the intervention had an effect of gestational weight gain in normal weight women, but not in obese. However, the intervention had an effect on postpartum weight retention in both normal weight and obese women. This might be made to think about that probably gestational weight gain is not a good measure. That's why we found that you find the effect at the postpartum, because maybe confounded by fluid retention, different placenta development, and in obese women, of course, given their higher weight, the possibility of measurement error is much higher. And so probably, and I'm doing a study on gestational weight gain, and intervention. Probably we should measure the weight of women 2 weeks postpartum as an outcome instead of the total gestational weight gain as a possible outcome. I'm done. Okay.
Do we have any questions for our panelists? Something that, I'll go ahead and start off, something that I didn't hear that much about, that maybe Dr. Gunderson or Dr. Ferrara can address. What's the research these days, the exercise during gestational pregnancies, that the woman has diabetes? How are those? Is that a good strategy? Dr. Duncan or Dr. Gunderson or Dr. Ferrara, whoever feels.
We just started an intervention on during pregnancy, so I cannot tell you how it's going yet. But I mean, I think moderate physical activity is possible to increase during pregnancy. Walking could be a good way to do it. And more than increase the physical activity during pregnancy is an intervention that stop the decline of physical activity during pregnancy that is usually observed.
Even from just the energy balance point of view, there's suggestions that, exercise improves the insulin sensitivity of the muscle cell, which would lower blood glucose. Is there any work suggesting that would be particularly?
In terms of prevention of gestational diabetes, definitely we will expect that they will improve glucose. We are conducting a study now looking at glycemic control by exercise level in women with gestational diabetes. But I don't have the result yet, and that could be another point to look at.
I look forward to those results. Yes.
I'll just make a really quick comment. I just used to do clinical care for Sweet Success program and doing treatment of women with gestational diabetes with Jack Kitzmiller and the CPMC group and over here. And when women did do the exercise, their blood sugars were lower clinically.
Yeah, and I'll just add to that, outside of pregnancy, that's what we see. I mean, exercise is recommended for, it actually can help not only with weight control, but also diabetes control. And so the trials they've done in pregnancy have not focused on GDM. They've focused on weight gain in pregnancy, and exercise alone doesn't seem to be enough to prevent excessive weight gain, although there's a couple studies that have suggested it might be, and so I think we'll see that. But it certainly has other beneficial effects outside of weight gain. So.
I am Simona Zompi, and I have a question, I think, for Dr. Catalano. There is some data suggesting that children conceived through IVF might have a higher, an increased risk of metabolic disorder. So I was wondering whether you were having that variable in your data, and what is your idea on that?
No, we're not studying that. I work in a safety net hospital, so we don't have much IVF, to be quite honest. So. I think that there are issues related to, artificial reproduction related to risk of anomalies, and there's some questions about that. And I think people like Kelly Moley have really addressed this, looking at the pre-implantation embryo and even the oocyte, the effects of the maternal environment. But I think I would defer, because I'm really not so familiar with that. But there are really some questions, and people are looking into it. I would leave it at that.
Patty Robertson from Lung Hospital Lactation Task Force. So, Dr. Gunderson, I have a couple of questions. You mentioned that, I don't know, the relationship between obesity and successful breastfeeding. We see a lot of increased maternal age, obesity, depression, and difficulties breastfeeding. And also a second question, I've had a pediatrician once, when I saw a patient for a 6-week postpartum visit, tell the mother to not breastfeed so frequently because the baby was getting too fat. And we've always, as obstetricians, wanted breastfeeding on demand, and if you could address those two.
Okay, so the first one, you're talking about delayed lactogenesis too, so the copious onset of milk supply for the infant. And what happens we did recently have a paper published in AJCN on that topic in our GDM SWIFT cohort. And the strongest predictors of delayed lactogenesis was maternal pre-pregnancy obesity and insulin treatment during GDM pregnancy. Those are two very strong risk factors. So, and others have published in that women who are obese have some sort of a suppressed prolactin levels, and they may have a little bit of a delay, and it's just that they need extra support. So I think, being vigilant and triaging assessments of women before they get discharged post-delivery is helpful in that regard. So the second question has to do with, remind me again?
Are pediatricians actually asking mothers to decrease frequency of
growth.
breastfeeding if they notice increased weight gain?
The growth in the babies. Now, is this this was at 2 months postpartum?
Correct.
You were saying? Yeah, so I when you look at the studies of the growth of formula-fed babies compared to exclusively breastfed babies, the breastfed babies appear, as a group, as a population, they have a slower growth curve through the first year of life. But you will see some babies that get quite rotund, that are completely exclusively breastfed. And I think that's a normal phenomenon of that particular individual's growth pattern, so that no one should be discouraged because of a 2-month-old looking a bit chubby. But I think we know very little about how maternal diet affects breast milk composition, and there are some very interesting work that's ongoing looking at breast milk composition, not only in non-GDM women, but particularly in glucose-intolerant women, to see how the breast milk, whether the breast milk depends on maternal glycemia and maternal metabolic status, which I think would help us modify diets in the future.
Thanks.
So there might be more sugar in the breast milk?
That's what Lois Jovanovic did a study on that a while ago, and it's the maternal hyperglycemia has to be quite pronounced, but she did find higher glucose levels in some of the type 1 diabetics who their breast milk. But they were in poor control. So, I mean, I think we don't really know very much about the breast milk of women with GDM because the study, and they're very difficult studies to undertake.
Oh, hi, I'm Amy Beck from UCSF. I had a question, I think partially for Dr. Phelan, but I guess anyone else who's sort of working in the intervention sphere. And it's about the question of hunger in pregnancy. And so I obviously have my own personal experiences with this currently, but I think just, I haven't really read literature on this, but I think anecdotally, women generally do say that they feel a lot hungrier, and it's certain, particularly in the 3rd trimester, which is the time when babies are putting on a lot of weight, moms are putting on a lot of weight. And then I was just thinking about what you were saying about in interventions, and in a typical diet intervention, you do need to have people expect some hunger and some degree of hunger. And so how do you modify that for the pregnant population, and then how acceptable have you found those messages to be to women? Because I think when you're a dieter and it's just your own health involved, you think, okay, if I'm hungry, that's a good thing. But as a pregnant woman, perhaps if you're experiencing some hunger based on the recommended calories, you might worry about, am I actually giving my baby enough? So I was just curious if you had any experience or thoughts on that.
Yeah, so it's a great question. So empirically, we measured hunger, craving, and nausea and didn't see significant associations that either moderated our intervention or even related to gestational weight gain. But clinically, when we're working with women on an individual basis, then, and some have higher cravings than others, of course, and we didn't modify our recommendations compared to what we do outside of pregnancy. So it's the same thing, identifying is it internal hunger or external hunger, and how do you, you have a better sense of control of the external cues that are triggering hunger versus internal, identifying what those are. We didn't have any women craving odd things, but if women were craving ice, you know, go with it. And so, but I didn't, Yeah, no, we didn't see any pica. It's low prevalent, but we didn't really change the intervention so much. And I think internal hunger, we have the women monitor their level of hunger. If it gets above a 6 or a 7 or 8, with 10 being this extreme hunger, we do make modifications to prevent, because you don't want a woman thinking she's hurting her baby because she's experiencing so much hunger. And so we would tailor it according to their perceived level.
Have you ever noticed more hunger in a woman with gestational diabetes versus normal pregnancy?
Well, all those thousands of GDM women, and I took care of all these normal non-GDM women for years too. I think it's an individual phenomenon, and I don't think people are evaluated based on their weight. I think the quality of their diet and their weight gain. So we try to give them more higher quality foods if people are losing a bit too much weight.
I just want to evoke the social ecological model because I would not want a pregnant woman to not trust her own hunger. But in our environment, it's kind of hard to know what we're doing and the kind of triggers around us, and it takes a lot of, you know, mindfulness and trust. And so I guess that I just want to add that it is a difficult situation, and I think it's really unfair to the women that we live in a society where it isn't easy to eat well. And so I guess I just wanted to add that and say, trust your own hunger, and you can check in yourself. And as a clinician, when I had a woman who came and saw me, and actually I was just talking with some people from San Francisco General, and they were asking if a woman has a BMI over 40 and she's not gaining weight, would I be worried? And I took them through the kind of checklist that I used to go through with, does she have enough food? Is she mentally healthy? Is she caring for herself well? Is she eating well? Is she somewhat physically active? Are there places you can tinker slightly? Like, it's one thing to be hungry and to go out and eat 6 donuts, and it's another thing to be hungry and sit down and eat a small salad with a glass of milk, right? And so I guess that I'm just saying there's a lot of qualitative information that one can use to answer that question. But until we change our culture, I think that pregnant women who are trying to be healthy have to do a lot of extra work. And I know Suzanne is starting to do more work with couples and with families, and I think that that's a movement in the right direction, but ultimately it really does take a village. And if we want to invest in our kids, I think that those investments are going to have to be big time. And these individual lifestyle interventions, you know?
You know, I think it can be done too from the point of view that pregnant women used to consume alcohol, and I rarely see pregnant women consume alcohol anymore. It's just like you give it up completely. And it only took education in that case. So I think it can be done.
So I just want to touch on that point a little bit, because I think we sometimes see where women receive education and they change their goals around health behavior, but then in the moment when they're stressed, they have a hard time enacting those behaviors, and they can be really hard on themselves, and it creates this kind of negative feedback cycle for them. And that's part of what we are hoping with a mindfulness-based approach to intervention, that women can bring some self-kindness to their approach, but also develop, as in some of the work Alyssa, Barbara Laraya, and Nancy Adler are doing with the MAMA study, and I know we have other people from the team here, around inner and outer wisdom development through mindfulness skills, that you really, have this knowledge, but then also think about in the moment to moment aspects of your day. How does this play out, and how can you notice subtle cues in the body, notice satiety cues, really notice the quality of food and how you feel after you eat it, and so to begin to make some more sort of wise choices based on that sort of inner knowledge, but then as a group, perhaps in the, I mentioned the Centering Pregnancy Intervention, develop some collective wisdom as well.
Danny again from UC Berkeley. I'm happy, Larissa, that you mentioned the Mama study because that leads up to my next question. And I'll call out Barbara and Barbara again. I've been lucky enough to practice mindfulness with both of these phenomenal ladies. And so my question is, we are obviously highly educated white women. And so when you are doing an intervention, when it comes to various socioeconomic status groups and various social backgrounds, racial backgrounds, how are the women, how are they taking this? Are they accepting it? Because I know that my family back home thinks meditation is for hippies. Is this really a viable solution for the larger population? And how can we make it a more viable solution? How can we make it more socially acceptable? And Barbara and Alyssa, feel free to chime in too. I'd love to hear some insight from them.
Thank you for that really excellent question. That's something we've spent a whole lot of time thinking about and working with our community partners and providers and pregnant women to understand. And we've done a lot of qualitative work in our studies to get a sense of receptivity, to understand how kind of uptake of these skills and the information that we're sharing around mindfulness is received. And our main approach is to make sure we're really following secular models of mindfulness. So originally developed by John Kabat-Zinn with mindfulness-based stress reduction that we feel are very skills-based, and it's about also appraisal of how one interacts with one's environment and stressful events that might happen. And that we've found can be really quite complementary for people who do already have some other form of spiritual practice. We work with a lot of women who are of Catholic faith, and they found some ways that it's complementary. I had one woman say, I can pray better now because I can pay attention. My mind's not wandering as much, but it's this very behavioral skill that helped facilitate that. But then we also have elements that are focused on kindness, that have these other more sort of emotional characteristics, but that align with people's faiths at times. So we present it as something that people of any faith or no faith can practice. And we also spend time hearing people's sort of skepticism, or they may have some kind of inaccurate perceptions based on what's out in the culture. We incorporate mindful movement. Yoga is pretty prevalent, so people have a lot of different ideas about what yoga is or isn't, and we're really presenting it as a mindfulness practice.
Great, thank you.
Does the kindness element deal with being kind to yourself by choosing healthy foods, or is it forgiveness for deviation from a healthy eating pattern?
It can be both. A lot of what we are doing is an adaptation of loving kindness meditation that's really a well-wishing for oneself and others, but first for the baby, going within.
And I just wanted
of interconnectedness.
And I just wanted to chime in. When we were recruiting for mamas, we put flyers up about stress, that the intervention was to address stress, or if you're feeling stressed in pregnancy. And oh my gosh, women endorse the concept of wanting to deal with their stress. So I think that they were just so desperate and interested and intrigued with anything that would address the stress. We did focus groups and talked about the semantics around mindfulness, and for the most part, women weren't actually that adverse to some of the semantics. And as Larissa said, it's mostly the secular type components. What they didn't endorse was necessarily that they were overweight or that they had any concern about gaining weight. So the stress is a real driver for women. And the skills, the breathing, I think, in the breathing and being reflective and going inside, they've just got to be universal concepts. I don't think they're that strange for most of us, as long as the semantics are there and it's a shared experience. So we found really no problem with delivering the intervention. It was delightful and really important to women.
I think mindless eating is such a huge problem, and mindful eating sounds like the perfect solution, the whole concept. So I don't see how people could be adverse, like, this is weird. It makes perfect sense. Yeah.
Well, we also want to just give a little caution that it's not just this total acceptance of love yourself, eat whatever you want. Because I think there's often, and I experienced that in some of the mindful parenting work, that we're not encouraging parents to just accept whatever behavior their child exhibits. So you can use some of those principles with yourself, that you're really using a non-judgmental and caring framework, but that there need to be clear behavioral guidelines, and so that can apply to goals in one's own life as well as in relation to others.
Great, thank you. It seemed like there was, this is Monique Ketterson from Kaiser's Division of Research. It seemed like there was really a reoccurring theme today talking about the importance of the pre-pregnancy period, and given that we found sort of mixed results with the interventions during pregnancy, and the postpartum period is challenging for many reasons, I wonder if any of the panelists can comment on their thoughts about whether we're ready for pre-pregnancy interventions and what those might look like. Specifically, are there specific subgroups that we might want to target? Would it just be overweight or obese reproductive age women, or perhaps women with adverse cardiometabolic profile? Or would we want to go after women who are planning to get pregnant? I'm just wondering if anyone has any thoughts on if we're ready for pre-pregnancy interventions and what those might look like.
We need family interventions. And we need to start in about, I don't know how far back. I don't know if we have to start in preschool for the future mothers and fathers, or whether we start in high school. I mean, my kids now are pretty far away from high school, but I know what they learned in health, and it was nothing about nutrition. They learned everything. They went to Berkeley High. They learned, well, my daughter did. She learned everything about everything weird, but nothing about, she learned about every, a lot of reproductive health stuff, which is really valuable, but not a single word about nutrition, not regular gym. I mean, we have to make, I'm going to just go back to the statement that I feel like we need to work with the people that are preconceptional now, so we can try to help those babies and those mothers and fathers. But unless we make a major shift, it seems so, it's so weak to be pushing against these social determinants. And so I guess that's why I recommended to Barbara that she talk about that Ludwig article, which she didn't go into the detail, but he went off at the end and started talking about, changing the way we make our food, and changing people's knowledge base about how to choose food. But I think until we have a healthier society in all ways, these interventions are going to be, to some degree, destined to fail. I mean, Suzanne is the expert of all of us, I think, here on weight management and weight loss, and maybe you can add to this, because I think you're more optimistic than me.
Yeah, I do believe that long-term successful weight control is possible, and that you can lose weight. And I do think that, yes, the time is right for pre-pregnancy interventions in populations at risk and or not, or women with prior pregnancies or not. So I think we should go full throttle in studying interventions in that area.
Hi, I'm Nancy Adler, and I get the pleasure of the very quick summing up, which is mostly to express a lot of gratitude to the people who presented, the people in the audience. It's been a really full day, and I couldn't help but, I was sitting in the back and watching the backs of heads, and in so many of the presentations, people are really nodding. So this was a very engaged group, and the presenters were clear. They were concise, and they were on time. I have never been at a day-long symposium where everyone did exactly what they were asked. We also had an amazing team planning and implementing this. Alyssa and Barbara deserve a huge hand. And Jennifer Taggart and Stephanie Chernetsky, please stand up. Yes, stand for a second. And I just want to close by reflecting on what we've heard today. The question of stress and pregnancy and obesity is really such a critical problem. I do a lot of work with reports through the Institute of Medicine, and everyone wants to title their report, whatever their problem is, an epidemic. And the Institute has gotten very hard on that, saying, not everything can be an epidemic. I think we have an epidemic. I think the seriousness of this, I think the issue is made all the more poignant with the idea that children are starting off life on a trajectory that's going to be very hard to move, adds a great urgency to this. And I think the kinds of solutions that were represented by the panelists are hopeful signs that we're making some headway in dealing with this. This is a central question for SO and for COAST. I know we have a lot of acronyms and in different groups, but SO is the group across the campuses. COAST is our obesity group here, and the Center for Health and Community is the nurturer of COAST. We hope that you all will get involved with it. It's clear that the solutions for this cannot be done by any one discipline. It cannot be done at any one level. It's going to take people working at the level of basic research, of clinical interventions, and of policy. And COAST tries to represent all of those, brings people together, and to address all those levels. I think Alyssa at the beginning told you about some upcoming events. We're going to have a speed dating for introductions of people who might want to work together. We're going to have a workshop in 2015 to promote advances in the areas of collaboration between basic and clinical researchers. And we also we're using the website to create the virtual community. So we hope that you'll join us and put your bio up there and participate in all that we do. And thank you very much for your participation today, and special thanks to our presenters who did a magnificent job. Thank you.